Hello everyone, and thank you for joining us this evening. I'm here with Dr Nicholas Widmer from Switzerland. He'll be talking about EthOss, his experiences with EthOss and a titanium mesh. Due to the amount of people on the webinar, we've had to mute everyone. If anyone has any questions, please type them in the Q&A at the bottom of the screen, and we'll go through some questions for 10 minutes at the end. So I'll pass it straight on to you, Nicholas. Thank you.
Thank you very much. So welcome to everybody. My name is Nicolas. I'm a dentist from Switzerland. Bern is the most beautiful city in Switzerland, and you are all welcome to visit me. Around the city runs a river, and it's fantastic to jump in the river and take a swim. This is the staff and my office. I am using EthOss for now about 5 years, and I am also an ISC lecturer for ostomy implants. So most cases I show here are also with ostomy implants. The topic is using EthOss with titanium membranes. And I know it's not the first webinar and the weather is beautiful, so I already can say thank you for your attention. And also I want to thank Joe Harrison, Peter Wheeler and Peter Fairbairn for giving me the opportunity holding here a lecture. So the content is what are the principles of bone augmentation, titanium membranes, why to use them, when and how. And then if we have time, some question and answers. So the principles of bone augmentation. After extraction, it's very basic. We have, of course, a decrease of bone width and bone height. And finally, when we want to place an implant and we have insufficient bone to place the implant in the right position and to have the implant surrounded by bone and to get a good primary stability, very often we need bone augmentation. So when we think about bone augmentation, what are the key factors? What depends, when we can expect success and when we risk failures. It's dependent on the defect size and topography. The absence of infection is very important, the soft tissue closure, and of course, space maintenance and graft immobilization. If we think of this picture with the broken arm and the stabilization, we can see almost all key factors in these pictures. And today, of course, we are talking mainly about space maintenance and graft immobilization. The defect size and topography, we can divide into intrabony and extrabony defects. The defects can be small, like the hissens or fenestration, but a lot of the part of the implant is still covered by bone. And then the more complex cases, when we have vertical bone loss. So take a look at this picture. Here on the left side, we have the hissens, in the middle, a fenestration. And the clinical case is also the hissens. Even if it's rather a big dehiscence, I would say it's still an intrabony defect. Also, in this case, we have the CBCT. There's a lot of bone loss, but there are still the defects surrounded by teeth and by bone. So even this horizontal defect, I would say it's still an intrabony defect. On the other hand, The extra bony defect mostly appears when several teeth are missing. We have a bigger resorption, and these implants, they do not have neighboring structures like teeth or bone. So in the extra bony defect, the implant is placed partially or a lot of the part outside the bone housing. Okay. Now, the absence of infection is, of course, very important. It's also very basic. We always look for no infection. Chronic infection is maybe still okay, but acute infection, we risk a failure. How we can prevent this? I personally like to give my patients antibiotics before surgery. In almost all cases, is a standard protocol. But after implantation, I only give antibiotics when I see a higher risk of infection. The disinfection is very important. The rinsing, more rinsing is better, and this is often forgotten. I see in my assistant doctors, they do everything well, but they forget to rinse the bony defect. Then what also really can help is a proper degranulation. Helpful are serrated Lucas curettes. Now you can buy them from different manufacturers. But the real game changer, in my opinion, is the degranulation burr. So you can use this burr dry and slowly, and then you can use them with a lot of water for the cooling with better speed, and then you have also dissolution effect. Okay, so soft tissue closure, of course, very important, and it can be a difficult topic. It's difficult sometimes to have a primary closure. So it's easier to get a closure with bone augmentation when the gum is already healed, of course. So late implant placement, early implant placement, maybe after 3-4 weeks after extraction, or early socket graft, that is much easier. So we run a little bit a higher risk together with bone augmentation when we do immediate implant placement, immediate socket graft, or really large lateral augmentation. Then we need probably to release the periosteum. And it gets even more risky when we do combinations like immediate implant placement and a very large lateral augmentation. The space maintenance, graft immobilization, so we're coming to the main topic, is very important. Here in green letters, what really helps are immobile existing structures. I will explain later. Or by example, a fixed provisional will also help. Then maybe a non or slow resorbable graft with collagen membrane in combination, so the classic hydroxyapatite materials can also maintain the space, but also a self-hardening graft material like EthOss is very helpful. Then we can use additional supporting structures. I will talk shortly about that. Then, by example, a suck-down provisional is quite good because it's supported by the neighboring teeth and it gives no pressure on the bone augmentation. Then, by example, a Schneiderian membrane, there's always a little bit of movement of the Schneiderian membrane. And some materials work better in the sinus and some not so good because of this movement. Then, of course, the mobile mucosa And then really a problem can be lip and muscle pull. And then some of the worst is the pressure from professional or mastication, like in this picture. It's a Valplast professional. So you can do the most beautiful bone augmentation with all nice techniques, and you can ruin the case with a bad professional. So keep this in mind. We always talk about, I don't know, this titanium membrane and this fancy technique, but sometimes we forgot the basics, and especially when you are a supervisor office, maybe the general dentist, they do something wrong, it can happen. Okay, space maintenance. What do I mean with natural supporting structures? It's of course mainly the bone. Look at this case, a perio case, horrible pocket. I had to extract this tooth, but probably even not very well visible in the X-ray. There are still some attached fibers on the root, and the peak is quite high. So this is still an intrabony defect, and I had luck. The gum is very thick, and also a very thick gum, especially in the upper arch, can help also support the EthOss. And here I used also a high cover screw, and I get a very nice result. Even I had a lot, I had too much bone. I had to drill away the bone during second stage. But it's no miracle. The reason is I had still bony peaks or collagen fibers on the neighboring teeth, and the defect was not so big. It was still an interbony defect. So I had natural supporting structures. What do I mean with graft immobilization and non-resorbable? The collagen membrane, it was always told the main reason is to block the epithelium to grow in. But also important is the graft stabilization. There are more stiff collagen membranes, but there are also elastic membranes, which we can fix with tacks. And if we have some tension, the collagen membrane is pressing the hydroxyapatite on the surface. So we get also a stability by this tension. But of course, we get a shrinkage. And that is one reason when we use hydroxyapatite, we often have to overgraft, which is not the case with EthOss because it's totally different concept. So what is EthOss? It's a self-hardening graft material, and it contains of beta-tricalcium phosphate and calcium sulfate. And calcium sulfate actually is gypsum. So when we mix it, it's hardening. It's not going to get rock solid hard, but quite hard. So also with EthOss, we have stabilization immediately because the material is hardening itself. But I was thinking about this when I did the lecture last night. Maybe there is also kind of a stability dip in graft materials, also in EthOss. When we take X-rays after placing EthOss, maybe after 4 weeks, we often see a hollow in the X-ray. This is because the calcium sulfate is resorbing fast. And maybe even the EthOss is very stable when we place it. It's maybe possible that after 2-3 weeks, we do not yet have a very good bone regeneration, and we have maybe a stability dip. Similar, we have it when placing the implants. So here in this video, I place the EthOss directly out of the syringe. Then we can use an instrument to give the shape, but we should not really push it, just shaping it. Then we use a dry gauze and place it for maybe 3, 4, 5 minutes. And during this time, the calcium sulfate is setting and the ethos is hardening. And then we can easily suture. Before I mentioned the Schneiderian membrane in the sinus. When we do sinus lift with EthOss, we see better results when we do simultaneous implantation. Because it is difficult to harden with the gauze the EthOss in the sinus, it's maybe not getting rock solid in the first moment. But when we place together with the EthOss an implant, the implant itself is working as a tent pole and is stabilizing our EthOss. On the other hand, when we do, let's say, delayed implant placement, we do maybe lateral augmentation, like in the picture on the left. We place EthOss and we wait maybe 12 weeks and then we place the implants. We don't have this stabilizing effect of the immediate implant placement, but the Schneiderian membrane is still moving with breathing a little bit. And so in this case, we accept a little bit of consolidation of our graft material, as you can see in the lower left picture. It's not a big problem, but that may be an explanation. Then we can add structures, as I already mentioned. The implant itself can act, in this case, like a tenting pole. What is also very helpful can be a high cover screw. It can be a normal shape, but now they will enter the market from different brands. Mushroom-shaped cover screw, and they can protect the graft better. If you take a look at these pictures, I had also extract these tools because of perio and endodontic reason. I still had natural supporting structures here, a bony peak on the mesial part, but on the distal part, the bone peak was low because of the pocket. I placed the implant with a simultaneous internal sinus lift and EthOss, of course, and then I placed this high cover screw. And doing second stage or impression taking, you can see these principles here. On the mesial part, where I had a high bone peak and a high cover screw, the EthOss buildup was maintained. Whereas on the distal part, I had a high cover screw, but the bony peak was low because of the pocket. My bone augmentation was gone. So this is a good example to see how these supporting structures work. Or another interesting case. Here, I extracted these tools. I put an immediate implant and 2 other implants. The angulation is not ideal. That's another topic. Always when I do immediate, I place it quite deep. And here, I placed it also deep. And here on the last implant, I put a high cover screw. And even I placed the implant deep, you see a bone resorption here, almost up to the implant shoulder. Here it's a little bit better. And here the bone is over the implant shoulder. And the reason was the supporting additional structure, the high cover screw. I was thinking it will not be needed here because I have a tooth, but maybe the patient was chewing here and I don't know what was the reason. Then there's a very interesting technique There is also an EthOss On Demand training academy. You can watch a lecture. It's graft stabilization and space maintenance with slow resorbable suture. Here, a case from Dr. Fairbairn, and I have to admit, I also use it more and more. It's very cheap to use this material and very easy. It works well. Then there are the more complex techniques, like the cortical shell or lamina de Cori technique. You use block grafts, you stabilize them with screws, and you fill the gap with autologous bone or mixture or whatever. It works very well, but in my opinion, it's quite a difficult technique and also invasive. But what is a similar principle, but less invasive, are the titanium membranes. So the titanium membranes, why to use them? It is clear. We use them for space maintenance and graft stabilization. We use them, or I use them, because titanium has a very good tissue compatibility. With this system, at the moment I use, it's awesome, it's very easy to use, and the cost is okay. It's also a well-documented technique. By example, this picture was taken out from an article from the Nature journal, so a journal with a high impact factor. It's less invasive than cortical shield technique. It has wide pores, and this might be an advantage together with EthOss. In my opinion, the titanium membranes, they can push the limits of EthOss. I don't use the titanium membranes like we learned for GBR technique to block the epithelium. It is not needed because with EthOss and the calcium sulfate, we have kind of an internal membrane. We don't need to block it. It's anyway another topic if it's really true, if we have an epithelium ingrowth, or rather because of movement, the mesenchymal cells are differentiating into fibroblasts. Because when we think, also when we used, or I used hydroxyapatite together with collagen membranes, sometimes I did not get a good result. And I blocked everything with the collagen membrane. So one possible reason was that I did not a good graft stabilization. Okay, so with EthOss and titanium membrane, the concept is different. The membrane is not used to block against soft tissue ingrowth. Rather, I prefer the big holes in the membrane to let the periosteum differentiate from the mesenchymal cells to the osteoblasts and migrate into the EthOss. And this may be one reason why we can see with EthOss much more bone after a short time compared to other materials, because we don't need and don't have to use a collagen membrane. Instead, when I use titanium membranes and I take a close look at the bone, when I remove the membranes, I even have the impression there is often kind of bone outgrowth out of these small holes. Look at this picture here, these small, I don't know how to call them, but they remind me of a table tennis racket with these grooves and shapes. Okay, but titanium membranes, they surely have also some disadvantages. It's an additional cost. You need maybe some instrument. The technique is maybe sensitive, not placing the implant, but the soft tissue management. the kind of titanium membranes I use now, they are not available for all the implant systems. And of course, they are non-resorbable, so we have to remove them. In the future, there will be also a stiff resorbable membrane. Okay, when and how to use them? I use them when there are big interbony defects or mainly extrabony defects, and when I risk a muscle pull. Generally lower posterior area and often upper canine region. By example, here on this CBCT, I placed, it was a canine region, and here I risk muscle pull, and this is for me a very good indication for titanium membrane. You can also see an interesting case. I placed 3 implants. The mesial implant with a high cover screw, the implant in the middle with a titanium membrane, all this here is EthOss, and the third implant I placed deep with a high cover screw. And now you can see here, the X-ray is not so good, but you can see a bone resorption up to the implant shoulder. But where I had the titanium membrane, my bone augmentation was good. I had bone growth over the implant shoulder and here also, but here the bone was already high here. Okay, what kind of titanium membranes we can find on the market? There are these standard ones. Then there are the 3D pre-shaped ones in different sizes, that the one I use. And now entering more and more the individual CAD/CAM produced ones like the EthOss. I don't have experience with this one. I cannot tell you a lot about this. But about 10 years ago, I often used this kind of membranes. It was a standard size. I had to cut it and bend in the correct shape. But I used it this time together with xenograft. I mean, results were good, but the handling was very complicated, and also some problems like dehiscence happened quite often. One problem is when you cut it, you get sharp corners. Then this kind of titanium membrane has to be stabilized with special screws. And when you screw it in, it deforms the membrane. And they have been, together with hydroxyapatite, very difficult to remove. There was really a little bit of ingrowths of the soft tissue, and for removing, I had to do kind of a dissection. It was difficult, but it's cheap and you can use it with every implant system. What is better, in my opinion, are now these 3D pre-shaped titanium membranes. They are different brands, but most are Korean brands like Allstem, Neobiotech, Megagen, Dio, and so on. But there are third-party manufacturers like this golden anodized one is also cheap. You can use it. The advantage is they are pre-shaped, they have the right shape, but you have to select. They are very thin, 0.1 millimeters. They have round the corners, they have an optimal structure, and main advantage, you fix them with the implant. How does it work? We have here an implant, and then the membrane, in case of a bone level implant, is not placed directly on the implant shoulder. You have a space maintenance by a so-called anchor screw. And then you fix the implant on the anchor with either a cover cap or a healing abutment, depending on the case. The titanium membranes, they come in different shapes, depending what kind of defect, what kind of shape you need. There are more complex ones, but some of these are not available in Europe, only in Korean market. So you have to measure your defect. You need maybe a stock of these membranes in your office, Or when you have a CBCT, you always can evaluate what kind of membrane you need. But finally, in my office, I only have 3 different ones. That's enough. Okay, this is how it works. First, you place the anchor and you place the bone graft, and then you place the titanium membrane. You can also do it the other way around, first placing the membrane and then the bone graft, but there are some disadvantages when you do it like this. And then you use the cap, the cover screw, or the healing cap. The anchors are available in different heights, depending where you place your implant and maybe depending on the tissue thickness of the mucosa. Okay. So here a clinical case. You can see before the treatment, it was already an implant on the lateral incisor, and here the canine was fractured. After removing the canine, there was a big defect and not adequate bone volume. So I placed the implant together with titanium screw. You can see here the anchor is a 2 millimeter height anchor. And you can see here in the DVT, it's very small, the titanium membrane and the EthOss. And the final result was very good. But I did also a mistake. I cut the periosteum, and my titanium membrane was not very well adapted in the apical part. So the cut of the periosteum was about in the region where the border of the titanium membrane, and there can be a problem with the soft tissue. And what I get then was maybe a little bit of washout of EthOss and a so-called indurated hematoma. It's not a big deal, but it can take a lot of time, up to 6 months, to dissolve. So this is a critical part. You have to check that your titanium membrane is well adapted in the apical part to the bone. And this is the disadvantage when you first place the implant and you bend back. When you first place the titanium membrane, you bend it back to place the EthOss and then bend it. Then it's kind of a memory effect of the membrane, and it's not well adapted. So it's very important to control the bleeding and the adaptation of the titanium membrane. Here, a clinical case made together with my co-worker, Dr. Asemi, and I want to show you how it works clinically. So I have to search here for the placement. Oops. Okay. It's about here. You can see it's important to do the periosteum releasing very early. You should even do it before placing the implants. Because when you do it just before or after placing the EthOss, you risk bleeding, and this can be a problem that the EthOss is not hardening as it should. Okay. Then I go to this time. Now you can see the anchor is already placed on the implant, and it's the fitting in of the titanium membrane. So with this system, when you can stabilize the membrane with the implant, it's very convenient. So you can see the membrane, you can hold it with the pliers, and then you can use this, in this case, it was a cover screw, and fix the membrane. Okay. Now, here you can see how the EthOss is applied. This is the other possibility, that you first place the membrane and then the EthOss. But normally I would recommend to first placing EthOss and then the membrane. You see, now you have to bend maybe a little bit the membrane, and this is not ideal. That was also the mistake I did with this hematoma after. But it is possible. In some cases, it will work, of course. So you can place the EthOss below the membrane, and you can also easily dry the EthOss through the membrane with the gauze. It's not a problem. The problem of this technique is the apical adaptation of the membrane. Okay. Now here is the result about 12 weeks later. The implants are placed a little bit too far to the buccal, but look at this bone. It was really no bone here, and we have new bone after 12 weeks. And because we used 2 millimeter anchor as a space keeper, our implants are really totally surrounded by good-looking, well vasculated natural bone. That is, for me, really amazing. And it was also this picture, when you take a closer look, you have the impression that the bone was growing out of the membrane. The membrane is easy to remove. It was not really needed to make such a big flap. It was just to show the good bone healing. But when you detach the anchor, the membrane normally comes just with the anchor, because it pulls out the membrane. So you can do rather a small cut. It's easy to remove. Okay, now I can give you a very quick demonstration how to use it. I prepared a model here. Then I have here the Smart Builder. They come sterile. This is, by example, one for easy augmentation. Then the anchor in different heights. This is the 2 millimeter one. And here, very small, the cover screw. Or other possibility to use something like a healing cap, when we have good stability, non-smoker, good tissue, and so on. Okay, so what I will do first, I will place the anchor, and then I will mix the EthOss, place the membrane, and that's it. So what I need is just the cover screw. I take my anchor, and I finally just have to screw it in. And this gives me a nice distance. By example, I take a look that the implant, that the top of the anchor is maybe leveled with the bony peak here. Okay. Then I use EthOss. I push back the handle. I loosen a little bit the material, and instead of doing this movement, I just turn it a little bit, then it comes off easily. I use a sterile saline, like this. Okay. I put back the cover and I mix it. Okay, so I'm happy with that. I lose again, and then I use a sterile gauze. And in this case, I do a so-called dry mix. So I push quite hard against the gauze. Quite hard. Look at this. Okay. And then I turn it a little bit, not to lose any ethos in the gauze. Okay. I take my patient and I place it directly. I place it directly on the implant. Okay. Like this. Okay. Then I use an instrument to give the right shape. And a very good instrument is sometimes the finger. Okay. Like this. Maybe here a little bit. Okay. And then I take the sterile gauze. I press, but I have to take care when, by example, my assisting is doing this step, pressing in the right direction, not that I push down the ethos to the apical. So that I also push, it's not really pushing, it's just drying in the right direction. This will take maybe 3 minutes normally. In the meantime, I often take a coffee. No, it's a joke. I prepare my sutures. Okay. And now it's already starting hardening. I can check. It's not rock solid, but it's good. Okay. Then I can take the membrane. Okay. I can place it. Okay, like this. And I use my cover screw to fix it. What is nice with this screwdriver, it has a conical shape. So when I pick up the cover screw or healing abutment, it's not falling out. So it's convenient to use with one hand. Okay, let's go back. Place the membrane. And fix it with the cover screw. Okay, it's really simple like that. Now, when I see that I have not enough ethos, I still can put some ethos here below, but because of the big size of these holes, it's even possible to put the ethos through the membrane. Look at this. So really very convenient to use. Okay. That's it. Okay, how to use them? Here another clinical case. Lower posterior, a difficult area. I placed the implant. There were many threads out, not very good stabilizing neighbor structures like bone. So I decided to place the titanium membrane. And here, what is the problem in this region? It's the releasing incision because of the foramen. So what I did, I made a releasing, but I made also a flap, a second releasing distally, and I made a lateral movement of the flap. And I used a healing cap instead of the cover screw, so it was easy to close the flap thanks to the healing screw. Okay, so periosteal releasing, how to do it? Of course, it's important to use a fresh blade. You should do only one cut, normally starting in the mesial part. And is the question where to cut? Deep in the muscles or rather more to the bone crest. So I try not to cut too deep, just where the muscles insert. And then I do one cut and very superficial. You can see the periosteum like a grayish, shiny skin. And then what I do, I use an instrument like a pre-shard and I stretch the fibers. Okay. Take a look here in this short video, how to do it, periosteal release. So grab the flap with the pliers, use a sharp blade like number 15, stretch the flap and do one, if possible, one cut like this, but well to the end of the flap, but not too deep. We don't want to cut too many muscles, too many vessels, or to risk perforation. And then I use an instrument like the end of one end of the pre-shard, and I stretch the muscles and look by stretching how much release I get. Okay, I also tried out the Schukrun brushing technique for not having any bleeding, but personally, it didn't work so well for me. But when you do the releasing and you build up your ethos and then you do the releasing, you may feel like a child doing a sandcastle on the seaside and a wave is flushing away your castle. So that may be a problem, bleeding. So think ahead of the releasing and do it in the beginning of your surgery so you can control the bleeding. But maybe you have still some bleeding. So what you can do is use anesthesia with high adrenaline concentration. And what really, really helps is the cyclocapron. It's a game changer in my opinion. I always gave it to my patients when I extracted a tooth, let's say Friday, they go to the weekend, I am not in the office, and they have some blood thinners. But you can also use it directly in the mouth. There are tablets, you put it in water, they dissolve. You can dip a gauze in this water and push the gauze on the bleeding side, and this works very well. If I still have, if I still think they could be bleeding, sometimes I use the sinus fleece. The sinus fleece is collagen, but it's not a membrane. It's more like a sponge, but a larger one. So it's going to be resorbed very fast. It's important for the periosteum and osteoblasts, but it gives me a stabilization against flushing away the ethos. Then how to do the flap design? It's good to start on the lingual side, not on top of the implant, more to the lingual side like here. And then when suturing, pay attention that the stitches on the lingual side are far away from the incision. This way you get a pull effect which is very important. Sorry for my drawings. Then what you also have to think in the beginning of the surgery, that the flap incision, the flap is big enough. Because when you use the titanium membranes, your flap should be at least 3-4 millimeters wider than the titanium membrane. Otherwise, you risk dehiscence. You can do papilla preservation flap if you have enough space, if you use a small titanium membrane. But when you do releasing incision and you pull the flap, then it's advisable to do a shape like this. Because your flap behaves like a piece of rubber, like this glove. When you pull it, it gets longer, but it also gets thinner. And when you do this parabolic shape incision, you will not get dehiscence on the lateral side. Okay, so this is a small tip. And suturing when using titanium membranes or the whole soft tissue handling is the difficult part. So make good stitches, do not make an inversion of the flap. That is not good, but an eversion. By the right needles, the right technique, and it's very advisable to use a horizontal mattress. But sometimes too much is not good. You can have a killer loop effect when your sutures are too close and your flap can become necrotic. So you can do single mattress, single by example, and a good number is about always leaving 3 millimeters between the stitches. Then we're coming to the end. What I often see is when doing the suturing of the releasing incision that it is orientated like this. But here, this part is fixed and the flap is mobile. So the mobile part always moves to the fixed one when you tighten your suture. And when you have this angulation, instead of this one, you pull down your flap instead of pulling it up. And then other mistake, try to put the knot on the attached tissue and better on the fixed part. One problem could be when you do a papilla preservation flap and you leave here maybe 1.5 millimeters to the papilla, that you don't have enough space to make here another small tiny suture. And what works well in my hands is histoacryl. I know it's not biological, but it works. It's glue. Okay, that's it. Thank you very much for your kind attention. If you have questions further after this lecture, please feel free to contact me at my Gmail, nicolas.widmer@gmail, or by Facebook or whatever. Thank you very much.
Thank you very much for that, Nicholas. It's very interesting. I've just got a couple of questions in so far. If anyone has any more questions, just type them in the Q&A box at the bottom of the page. So the first question, instead of using the anchor screw, why don't we put an implant higher and retain the membrane with the cover screw?
Instead of anchor?
Yes. So instead of using the anchor screw, why don't you have the implant higher and retain the membrane with the cover screw?
It depends on the implant design. If you have an implant with rough surface up to the shoulder, a bone level implant, you should place the shoulder of the implant about 4 millimeters below the free gingival margin. When you have less mucosa thickness, you risk bone loss.
Right. Okay. I've got a question here. Where do you buy your titanium membranes from?
I use the Ostem implant system, and they are specific for this system. Other systems, they have titanium membranes are Neobiotech, Megagen. I think you can buy them in the UK. And the golden one, it's a third-party brand. It's not expensive. I think it's called implantshop.eu, Europe, I think. It's an Hungarian company, and they have a little bit a different shape. You can use them also without anchor and fix them with the cover screw from your implant system. I think the anchor is better, but this would be a solution for the ones who do not use Ostem, Megagen, and so on.
Okay. How much time do you wait to remove the titanium membrane?
12 weeks.
12 weeks.
When I use titanium membranes with hydroxyapatite, I used EthOss. Then I removed the membrane often after 6 weeks because I have seen more infections. But with EthOss, so far I didn't have any infections. Now I have a patient, she was sick and she came back 2 years after I placed the titanium membranes, and she has no crown on the implant. And you can see shining through the titanium membrane through the gum, but it's no infection.
Well, and just a last question here. How far can you push the EthOss regeneration using a titanium mesh?
I don't know. I don't have so much experience. In my hands, I did some vertical augmentation. I think when I have good tissue conditions, I can go maybe 2 millimeters lateral and vertical. Maybe more is possible. I don't know. I will try out.
No, thank you very much for that, Nicholas. If no one else has got any questions, thank you all for joining us this evening. And we will be sending out a recording if you did miss any of it. And yes, thank you very much, Nicholas, for your time and the interesting topic.
Thank you very much. Have a good evening, everybody. Bye.